Okay, welcome everybody. We're going to talk to you about accommodation and over-accommodation of communication in aging. My name's Jean Gordon, and I'm trained as a speech-language pathologist, and I'm also an associate professor in communication sciences and disorders. My co-presenter here is Clarissa Shaw. She's trained as a registered nurse, and she is a PhD candidate in the College of Nursing. So I'm going to share my screen first and talk to you a little bit about language and communication, and then I'm going to pass it over to Claire, who's going to tell you about elderspeak. Okay. So I want to start by giving you a little bit of background information on what communication is. Communication is both transactional and interactional. So when most people think about communication, they think of the transactional sense of communication, which is the exchange of information. So in a lecture or a talk like this, I'm giving you information. When you're doing a patient interview, you're gathering information from the patient. And when you're explaining certain healthcare procedures, you're passing on information. But at least as important, probably more important than the transactional aspect of communication is the interactional aspect of communication. It's the interactional function of communication that allows us to create and maintain social relationships. And this is also important, of course, in the healthcare setting. It allows healthcare professionals to develop rapport with their patients, which is going to facilitate comprehension of information and compliance with healthcare recommendations. Regardless of the purpose of communication, it consists of multiple components or tools that are used to convey messages. And these domains of language are things that we as speech-language pathologists assess to see if somebody has a communication disorder. So semantics refers to meaning. And so this refers to the way in which we take an idea and encode it into linguistic form. So we translate it into words or phrases that that convey that meaning. And in English, there are lots of options for what words we might choose to convey a given idea. So this little idea, the simple idea, we could say cat or kitty or kitten. And choosing the phrase kitty cat also conveys, what words you choose also conveys certain aspects of meaning. So saying kitty cat might convey that we think this cat is very cute. So that's semantics. Syntax refers to grammar. How do we structure our sentences to convey a certain meaning? And again, in English at least, there's lots of options for how we might structure a sentence and vary the complexity and use our grammar to highlight certain words or certain parts of the sentence. Articulation, speech, refers to how we pronounce words, but also how quickly we speak and how we modulate our tone of voice. So that modulation is referred to as prosody or intonation. So we might use different intonations to convey different aspects of meaning. The kitty cat is playing, or, oh, the kitty cat is playing, will convey different meanings. Pragmatics is a broad category that includes how we adapt aspects of verbal language to the social context. So we might vary the types of words we use or how complex the grammar is. We might vary how carefully we enunciate words. We might vary tone of voice, but it also refers to aspects of nonverbal communication like the use of gesture, eye contact, or proxemics is how close we stand to someone. And we're going to vary those things depending on the context. Who are we speaking to? What kind of relationship do we have? Our interpersonal dynamics, and what is the purpose of the communicative exchange? In addition to those aspects of language, communication also involves other cognitive processes, such as the ability to sustain attention to a lecture or conversation, the ability to remember the topic of conversation, and then certain executive functions, for example, the need to inhibit the use of swear words in certain contexts. So cognitive processes, sensory processes, such as using hearing to understand spoken speech, vision to read, but also to pick up on nonverbal cues like gesture and facial expression. Motor processes are also involved to program and move the oral articulators for speech, or to program and move the hand for writing or gesture, for example. So between all of these aspects and domains of communication, there are lots of age-related problems and disorders that can affect these different aspects of communication. I've got some of them listed here. So how is communication affected in typical aging? Research suggests that the most common changes tend to be in the more peripheral processes rather than the more central cognitive processes. So there are declines in sensory function that are common with aging. For example, about 2/3 of adults over the age of 70 show some degree of age-related hearing loss, which is referred to as presbycusis. There are also common declines in motor processes and structural changes that affect output. So vocal changes are common with aging. This is referred to as presbyphonia. It's also common that our rate of speech slows with aging, with typical aging. One common cognitive linguistic problem that does occur with typical aging is word retrieval problems. And we refer to these as tip of the tongue states. We all have these from time to time, but they get worse with anything that places a demand on cognition. So if we're tired, for example, we're more likely to have these tip of the tongue states. And they increase with typical aging. However, they're not a sign of more generalized memory problems, even though many people are afraid of that. They worry that if they forget somebody's name, then that's a sign of the onset of dementia, but that's not the case. In fact, our vocabulary knowledge, our word knowledge, is well preserved in aging and is often shown to be better than younger adults. And there are some who think that it's this expanded vocabulary that accounts for age-related word retrieval problems, with the idea being that as we gather more words, it becomes more difficult to sort between them and identify the correct word that we're looking for. Like vocabulary knowledge, general knowledge is well preserved in aging and accumulates throughout the lifespan. And along with the accrual of experience, this accumulation of knowledge can result in better social judgment and even a certain degree of wisdom. So overall, in typical aging, communication declines are pretty minor, mostly in these peripheral processes, and there can even be improvements in communicative abilities. However, there are also some age-related disorders that occur that we need to be aware of. So presbycusis is one that I already mentioned. Although the majority of older adults have some degree of hearing loss, there's a smaller proportion that develop more severe loss that significantly affects their communicative function. Stroke is another common age-related disorder. that can cause problems either with the motor aspects of speech production, referred to as either dysarthria or apraxia, or with language processing, which is referred to as aphasia. Aphasia is a disruption to all the modalities or channels of language use, including speaking, listening, reading, and writing. Another common age-related disorder is our progressive neurological diseases, and they can also cause speech or language problems. So motor speech disorders, such as dysarthria or vocal tremor, are common with subcortical dementias like Parkinson's disease, and language problems are common with cortical dementias like Alzheimer's disease or primary progressive aphasia. And those typically begin with increased difficulty retrieving words and can progress to, or often do progress to, more significant problems, including the use of nonsense words, the inability to follow the topic of a conversation, and eventually can result in mutism. So with such a wide range of communicative abilities, this creates a dilemma for those who interact with older adults. And that's captured in the communication predicament model shown here. So what happens when you encounter an older person is that these peripheral changes in aging, including ones I mentioned, such as changes in the voice, change in speech rate, but also aspects of appearance, white hair, wrinkles, and also aspects of the context, like just encountering someone in a nursing home, can already lead to certain expectations. So these age-related cues are fairly obvious and immediately evident, and those can trigger expectations based on age-related stereotypes of broader cognitive and communicative deficits. So many people assume that aging involves an inevitable slide to senility, or that some degree of cognitive impairment is likely to be present. And so those expectations can be triggered and lead the person to modify their speech behavior according to the expectation of cognitive impairment. When those modifications exceed what's needed for that particular individual, this is referred to as over-accommodation. And that can have a number of consequences, including reducing the self-esteem of the older adult and reinforcing self-stereotypes. So the older adult might begin to perceive herself as being older than she is. And that can negatively affect future interactions, and this leads to this kind of vicious circle shown here. There can also be under accommodation, where the needed accommodations are not made. And so I have an example here, a little animated example for you to watch, and see if you can identify what verbal or nonverbal behaviors this doctor displays that fail to appropriately accommodate to his patient's communication needs.
Good afternoon, Mrs. Gifford. Please have a seat. I have your chart up here on the screen. Be with you in a minute. Just need to answer this email.
Hello, doctor. Should I sit down?
So, how are you? Any trouble sleeping?
Excuse me? I don't really know.
No? Okay, no trouble sleeping. That's good. How about pain? Are you in any pain? On a scale of 1 to 10.
How will I be paying? What am I paying for?
So pain is a 4. I'm sorry, I'll be right back.
Okay, so here is an example of over-accommodation. What behaviors does the doctor display? In this case, that inappropriately over-accommodate to his patient's communication needs.
Nice day out there today, isn't it, my dear? So how are you? Any trouble sleeping?
I'm sorry, could you speak up?
Sleeping. Do you have trouble sleeping?
Oh no, I sleep all right.
How about pain?
Pain? For what?
Oh, never mind. Let's just get on with the examination. Let me look in your ears.
Okay, there can be potentially appropriate forms of accommodation, particularly for individuals who have some kind of communication impairment. So one important strategy is to minimize background noise and distractions. That's really helpful for everybody, but particularly for individuals with hearing loss or some kind of cognitive impairment. Speak at the same level, make eye contact, use gestures or other visual cues that can support the verbal message. Be patient. Allow the older adult time to respond or time to formulate their own message. In other words, don't speak for them. Can be helpful to use shorter sentences and to pause more frequently, as long as you maintain a natural rate and adult intonation pattern that's appropriate to an adult. And particularly for people who have expressive problems, it can be helpful to verify their messages to make sure you understood correctly. Most importantly, adapt to the individual needs and preferences of the person in front of you instead of responding to stereotyped expectations or assumptions. Okay, I'm going to pass the presentation now off to my colleague who is going to share her screen.
Hi, so my name is Clarissa Shaw, like Dr. Gordon said, and I'm a PhD candidate at the College of Nursing. So I'm going to be speaking to you today about a specific type of over-accommodation, which we call elderspeak. So elderspeak is a simplified speech register used with older adults that sounds like baby talk. You may have heard of elderspeak. It also has some other names like infantilization, secondary baby talk, meaning it's baby talk to someone who's not a baby or an infant, to a secondary type of adult. Also patronizing speech. So we do think this occurs commonly. Most of the research done in nursing homes, where it's been found to occur in about 22% to 58% of interactions between care providers and nursing home residents. So there's some key attributes of elderspeak that I'm going to relate back to what Dr. Gordon talked about. So the first one that is typically thought of when we think of baby talk to older adults is related to semantics, so the words we use. So some of it is using childish terms, for example, jammies instead of pajamas. Diminutive is often thought of in the form of inappropriate terms of endearment, so saying sweetie, dearie, honey, those kind of words. Collectives is very common. So that's, for example, saying we're going to take our bath instead of, as a nurse, saying, hi, I'm with you with your bath now, because you're hopefully not taking a bath. And then third person reference. That one's a little less common, but for example, if your patient's name is, you would be saying, is Fred ready for his medicine now? So the next category is that pragmatics category Dr. Gordon was explaining. That's kind of the overall relation to the conversation. So for elderspeak, we tend to think of pragmatics in relationship to care and control. So as nurses, we really want to come across as caring for our patients because we often really care about our patients. But we also need to control the situation because it's a care situation and we have certain things that have to be done so the patient can get well. And so often with pragmatics, we see that interplay between how a nurse can control the situation while also appear caring. So the first example is directives and imperatives, and that's just appearing controlling. So for example, you must take this medicine now. Tag question, that's when you really need to control the situation, like get a resident to breakfast, but you want to appear more caring. So you say, you're ready for breakfast now, aren't you? Reflective, similarly, is when you're trying to soften the end by making it per yourself. So smile for me. And then some other examples are minimizing words or mitigating expressions. That one's very common in nursing. It's just a little shot. And then also exaggerated praise and laughing at or belittling a patient. The other category that is a key attribute to elderspeak is paralinguistics. And so this is most often related to that prosody. And when thinking about paralinguistics, really imagine baby talk to a baby. So one of the first studies about elderspeak took place in a nursing home in the 1980s. And what researchers did was record interactions between nurses and patients. And then they went to a daycare center and recorded interactions between daycare teachers and 2-year-olds. And then they had a group of undergraduate college students listen to the recordings, and the undergraduate college students could not distinguish 75% of the recordings between nursing homes and daycare setting. And a lot of that is related to that prosody or that pitch nurses use. So some people have a naturally high-pitched voice, so it's not always just about being high-pitched. It's also that excessive pitch range when changing your pitch while speaking. Also a sing-song voice, and then being very over-articulated, exaggerated, and loud. And that's often related to that assumed excessive hearing loss of an older adult, whether they have a severe hearing impairment or not. And then similar to that pitch range, also just changing your loudness from going from very loud to very soft. And then lastly, the category of elderspeak would be syntax, and that's related to the grammar we use. So often we think of short utterances and simple grammar that could be considered patronizing attributes when speaking to someone. So what leads to this? And this goes back to that communication predicament of aging model that Dr. Gordon described. And to sum it up, we think it's likely ageism, but subconscious ageism. You know, we see old age cues, so we assume we need to accommodate. And by assuming the need to accommodate, rather than selecting an appropriate level of accommodation, we over accommodate. Often this is from nurses who care deeply for their patients or other nursing home care providers who care deeply for their patients. And so it's not out of a place of malevolence towards the patient. So other antecedents to elderspeak, so what we think leads to elderspeak, is we know that elderspeak is more common with older adults who have a greater cognitive or functional decline. Sometimes it's not whether they actually have that greater decline or the speaker perceives they have a greater decline. And then sometimes people wonder, is it more common to female residents than male residents? And we're a little unclear on that. Similar to the speaker characteristics, you know, we get asked a lot, is it more likely for a female nurse to do it than a male nurse? And again, that's kind of unclear based on the gender of the speaker as well as the experience of the speaker. We do know that care staff tend to use it more than volunteers. And, you know, if you think about the relationship, that might make sense because the nurse or the care provider is often providing very intimate cares to persons who have maybe more of a cognitive or functional decline versus a volunteer that's doing an activity. So if you think about that caring and control continuum, the nurse is trying to come off as very caring by using the elderspeak. And then the other thing we know is that people tend to be either users or non-users. So if you're sitting here listening to this thinking, I never use this, that might be true. Some people use this 0% of the time. And then there are other people who just talk like this naturally and use it 99% of the time. Some people drop in and out of it depending on the situation, but there definitely are people who don't use it at all and who pretty much always use it no matter what the situation. And then as far as contextual and dyadic characteristics, there are some unclear effects of residence. So consider a community-based older adult who lives at home versus someone who lives in a nursing home. We think that elderspeak use is more driven by the cognitive or functional decline rather than just the setting itself. And then we would like to know some more research on familiarity and likability. So for example, are you more likely to use it if you're very familiar with the resident or not familiar at all? Or you really like the resident or don't like the resident very much? So what's the big deal, you might ask? So what are the consequences to elderspeak? So the things that come up are comprehension. Well, I use it, for example, because I think it helps the older adult understand me, or I think they perceive me as more caring, or they behave better. So we're going to kind of go into those and understand what the actual consequences of using this with older adults and or residents are. So the first one that's really common is comprehension. I speak simpler because it helps them comprehend. And that is somewhat true. So some syntactic changes that would be considered an actual attribute of elderspeak might actually help comprehension. So we think that this is more related to the simplifying of sentences rather than simply shortening the sentence or simplifying the words itself. So for example, if I was a nursing assistant and I went into a patient's room and I said, "Hi, John, your nurse, Kelly, will be in soon to give your medications." That's somewhat of a complex sentence because of where you placed that nurse's name. Alternatively, you could simplify the sentence by saying, "Hi, John, today your nurse is going to be Kelly. She will be in soon to give you your medications." You can see that's actually more words, but by taking out that embedded clause that the nurse's name, it might be simpler for the nurse to understand or the patient to understand. One thing we do know though is that if you take that same sentence and really exaggerate your prosody, it can negate any of those helpful changes in syntax. So for example, if you went in now and said, "Hi, John, how you doing, buddy? Your nurse is going to be Kelly today. She's going to be in real soon to give your medications." Even though you made those changes to your sentence to make it simpler, adding that tone might actually negate some of the benefits of the syntactic changes. So how do older adults perceive elderspeak? So generally, cognitively intact older adults think that people who use elderspeak with them are actually less warm, respectful, nurturing, supportive, intelligent, and trustworthy, which is opposite of what nurses tend to think. They tend to think that by using elderspeak, they are actually perceived as warm and respectful, while in fact, residents tend to think of them as patronizing. However, that's not completely universal. We do know some people maybe do like being spoken to this way. So it's about finding how to accommodate to the specific resident and not assuming that because an older adult has those old age cues, they want to be spoken to like this. So, however, a lot of residents in nursing homes have some sort of cognitive decline, and in these studies, it's hard to ask them what they perceive elderspeak as. So instead, there's been a subset of research that looks at the specific behaviors of persons living with dementia to see how they respond to elderspeak. So in these studies, they've looked at the resistiveness to care of residents. So that includes behaviors like hitting, pulling away, crying, screaming, and yelling. And so these studies look at specifically if elderspeak is used, is a patient more likely to become resistive? So the answer is yes. The probability of resistiveness to care doubles when elderspeak is used versus neutral communication. Now, when they looked at this in a randomized control trial where they measured resistiveness in elderspeak prior to an intervention, did the intervention to try to provide education to lower elderspeak, and then measured elderspeak and resistiveness afterwards, they found that the intervention both reduced elder speak by the nurse and subsequently reduced resistiveness by the patients with dementia, somewhat showing that causal relationship by how elder speak is related to resistiveness to care. So specifically, what they found is if you reduce your own elder speak by 10%, you're likely to reduce a resident's resistiveness by about 4%. So to summarize what Dr. Gordon and I have talked about today is, some of the syntactic changes of elder speak are beneficial. So that's providing that accommodation to an older adult. However, the benefits to those changes might be lost with excessive prosodic changes. In general, we can say that older adults do not like elder speak. However, that's not universal. So if you know a resident who seems to really like it, they may really like it. But we tend to think that nurses tend to drop into elder speak as a form of subconscious ageism because they're reading those old age cues. They're trying to figure out how to balance care and control, and this is how their communication becomes elicited. And then lastly, persons with dementia may not be able to self-report that they don't like elder speak, so instead they respond negatively through resistiveness and care. So, the question is, how do we accommodate? And that can be tough. So similar to the communication predicament of aging model, we have a communication enhancement model that's still based on the recognition of old age cues. And you might still need to accommodate, but instead of accommodating based on stereotypes of what older adults need for accommodation, you do an individual assessment to see what their accommodation needs are, whether that's a hearing assessment to see if they are hard of hearing, or to understand, if they have comprehension challenges and they need those syntactic changes. You can do an individual assessment to come up with the proper accommodation rather than dropping into using those words like honey and dearie and sweetie because you're perceiving them as more baby-like. So now we will go to the live portion of this presentation and take any questions you have. We thank you for your time.